from this phone, and I'm going to screen record from this phone. But I did find out that there is another thing I can use. And like I said, that I can put myself at the top like in a bubble, and then you guys, you can see everything we're using. So welcome back. I'm Nurse Shay. If you don't know who I am, I am the R-Influencer and your Nclex coach. So you can call me Coach Shay. I'm very excited for all of you that have returned. And I know we have somebody that has a test on July 11th. Welcome in, True Self. I'm very happy for you guys. I'm proud of you all, and you guys are doing great. Showing up is the first step, okay? So I'm very proud of you all for being here with me, and I'm very, very thankful that you guys have. Welcome in, Miss Chris too. Mrs. Chris too. That was a tongue twister. Anyway, I'm very glad that you guys have chosen me to be your coach, and welcome, welcome, welcome. Okay. So anywho, today and for the next 2 days, we're going inside the body. We're talking about lab values, the numbers that tell you what is happening inside your patient and when they cannot always tell you themselves. Okay. Here's what I need you to understand from the jump. The Nclex is not going to ask you to memorize every single lab value, okay? It's going to ask you this given result, all right? My kids. What does the nurse do next? The critical thinking question. This is the root stem. That is the root stem question. And over the next 3 days, we're going to master it. So basically, this is your scenario. This is what's going on. What are we going to do about it? Remember what I told you? We were talking yesterday about, talking about beta blockers, your LOLs, right? So we got our beta blockers, right? Or no, we were talking about diabetes. I'm sorry. You got diabetes, hypo and hyperglycemia, right? Signs and symptoms. The main things, and welcome in Simply and True Self. What can we do about it right now, okay? And that's what it is. Hang on, somebody was requesting to come up. That's what it is what can we do about whatever is going on right now, okay? So, pull out your reference card. It's a cheat sheet for today, okay? And keep it. You should laminate it, put it on your bathroom mirror. I'm not going to tell you to take it with you in the car, but you can put it in your console and look at it at the red light. Whatever it may be, make sure you're safe on the road. Welcome in, Jennifer. Your lab reference is your cheat sheet, okay? All right, now, the CBC is your first look at the blood. Think of it as the body's report card. So we're going to go through the big four, okay? We got hemoglobin, or HGB. I'm not going to talk to you like you don't know anything about what I'm talking about. So I'm just going to do it in our nursing terms. If you need me to stop, let me know. The CBC is your first look at the blood. Think of it as the body's report card. Let's go through the big four. The hemoglobin, normal is what? Does anybody know the normal hemoglobin? If not, you should have your reference card in front of you. Come on, y'all. What's the normal hemoglobin? Let's go, let's go, let's go, let's go. Let me know. Welcome in, Evan New. What is the normal hemoglobin, guys? Come on, y'all got to know this. This is important for your test. You have to know a normal. Thank you. Thank you. Thank you. Both of you are right. And the reason being is because it is a difference for men and women. Okay. Now, what is that magic number that we need to do a blood transfusion? Below what? Yep, that's right, Asher. Thank you, baby. So below 7, it's okay, Walk. Below 7 is when we transfuse, okay? And some people that may have like cancer or be on chemo or anything like that, oncology patients may likely be treated before they get to 7, but that's on another day. But right now, thank you, Sidra. Thank you, honey. Below 7. Below 7. Everybody put below 7 in the chat. Below 7. You guys need to know this. I'm telling you, you need to know it. I have not met a student yet. I feel like I'm not getting a good recording. I have not met a student yet that has not had that on their test, okay? Below 7. Below 7, they won't go to heaven, Walk, but that is a way to remember it. I had a patient, real talk, y'all. I feel like I need to change this. I'm sorry, y'all. I'm trying to record this for you all the appropriate way. I had a patient come into the ED. She had the same health issues that I have, okay? So I have chronic iron deficiency anemia secondary to gastric bypass surgery, okay? My patient came into the ED. Her hemoglobin was a 2.5. Now, she found this out because she went to her provider. I think we're good, y'all. I got it up there now. She went to the doctor's office, and for her checkup, she's like, oh, I'm tired, I'm this, I'm that, blah, 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 blah. Well, guess what? Her labs came back 2 days later, and yes, WAP, I'm serious. Welcome in, Sonny. She went to the doctor's office, and baby, for 2 days, right? It is crazy. So we had to do some, giving her some hemoglobins and some RBCs because, baby, all right? So the magic number is 7 most of the time, and 7 goes to heaven. That does rhyme. If that helps you remember it, absolutely. However, I've had a lot of people that are below that number, and it is not fatal. But I will tell you this. Life is too short. Welcome in. When they tell you they're having difficulty breathing, they're not playing. Okay, I literally just experienced this myself with my iron. My hemoglobin was not even low. My hemoglobin was 9.5, but my iron and ferritin and iron battery, all that, it was out of whack. I had gastric bypass surgery. True self, welcome in. I have to get iron infusions, and baby, when I tell you it was bad, it started, I remember the date, May the 16th it started. I literally was so worn out from breathing that I was going up the steps and I went to my knees, and it was bad. I called 911 and went to the ER. Okay. All right. We're going to stay on track. So below 7, the patient may need a blood transfusion. All right. My memory trick is healthy blood goes 12 to 17. All right. So healthy blood goes 12 to 17. Okay. Hematocrit is roughly 3 times your hemoglobin. So if hemoglobin is 14, your hematocrit should be around 42. Okay? Remember, hematocrit equals hemoglobin times 3. This is a quick sanity check on your labs. Okay? If they don't match up, something's wrong with the specimen and you need to repeat it. All right? So, healthy HBG, healthy blood goes, hemoglobin. Healthy blood goes 12 to 17. Hematocrit, HGV times 3. Y'all got it? Everybody got it? Everybody got it? Everybody got it? 1 in the chat if you got it. Come on, y'all. Talk to me, baby. Talk to me. I need y'all to communicate back and forth with me. Come on. Okay? Thank y'all. Thank you. Thumbs up works, Astrid. Thank you, baby doll. Pretty Ash, welcome in, love. White blood cell is, the normal for white blood cells is between 5 and 10. Below 5 is immunocompromised. Above 10, infection or inflammation is noted, okay? So my trick, 5 to 10, fight to win, okay? Below 5, the body cannot fight. Above 10, the body is already fighting. Does that make sense? I'm going to say it again. 5 to 10, fight to win. Below 5, the body cannot fight because they're compromised. Above 10, the body is already fighting. Okay? If y'all like it, you can have it. Write it down. All right. Platelets, 150 to 400. And I say 150, but 150,000 to 400,000. Below 50,000 is bleeding precautions. Below 50,000 is bleeding precautions. No IM injections, no razors. They need a soft toothbrush. Okay? Don't stick them 100 times for an IV. If you do, you better make sure you apply pressure to it, because if not, your patient's going to bleed. Okay? I have seen a patient have severe blood loss from an IV stick, guys. I'm not playing. It was insane. Insane. Below 20,000, spontaneous bleeding risk. Critical value, remember 150 to 400. Platelets, plug the pore. Your platelets plug the pore. So your platelets is what think of it as caulking or something. It stops the bleed. It helps stop the bleed. So it plugs the pore. PPP, platelets plug the pore. Do y'all like it? If you do, you can have it. Mrs. FD 4214, welcome in. Everybody, if you could tap the screen and share out the live. Everybody right now, hold your finger on my forehead and share out the live to 10 people, please. And tap, tap, tap the screen for me. Come on, y'all. All right. If a patient's hemoglobin is 6.8 and they are dizzy, what do you do first? What do you guys think you do first? Anybody? If somebody has a hemoglobin of 6.8 and they're dizzy, what should you do? So we're gonna, it's what we can do right away, right? So we're gonna check on our patient, make sure they don't have any abnormal signs of bleeding or anything like that, and then we're gonna let the doctor know, okay? Just wanna let y'all know. All right, now we're gonna do segment 3 for electrolytes and BMP. All right, BM. Jenny's Dreaming, welcome in, love. My name is Shay, I'm an Nclex coach, and I am helping my fellow peers, soon-to-be peers, get ready to conquer the world with this test. If you guys want to come up on the panel, you're welcome to. Just let me know. Here. Y'all can come up and mute your mic, and that way you get visibility too, guys. I do TikTok shop, so I'm all about visibility. Y'all want to make sure that you all follow each other and stuff too, so that you can support one another, because we're in this together. We are building a community of strong nurses, y'all. That's what my goal is. All right. These are the minerals in your body that control your heart, your muscles, and your brain. When they go out of range, patients can die. Okay? When they go out of range, patients can die. I'm looking at the other camera too. All right? It's not an exaggeration. That is physiology. All right? Sodium. Everybody put the Apple user, welcome in. Everybody put what is the acronym for sodium? I'm sorry, I said the acronym. What is the abbreviation for sodium? Lord have mercy. Everybody know it's the big N, little a, and the positive sign, right? So normal is 135 to 145. Okay? I'm going to show y'all a little trick. Did anybody learn the little pH trick when it comes to blood gases? Did you guys learn that? Y'all, my kids steal everything from me. They got all of my papers and everything else. All right. I'm looking for orange paper. All right. So the pH, 135 to 145. All right. Low sodium is hyponatremia. Low, hypo, low. Okay? Causes confusion. It can cause seizures. All right? The brain can swell if your sodium is high. Okay? Hypernatremia is when your sodium is high. Causes thirst and dry membranes. Think the brain shrinks. Trick 135 to 145. Sodium stays stable. Stable. I can't talk. Your potassium, the normal is 3.5 to 5, depending upon where you're at and if you're a dialysis patient or not, because sometimes that changes. Freedom Launch, welcome in. Okay? So some people have that reference range. I've seen it 3.5 to 4.5. I've seen it 3 to 5. I've seen it 3.5 to 5.5. It ranges between there. But we got, for the clinical reference, 3.5 to 5.0, and that is what the Nclex reference is. Write this down and tattoo it on your brain. Okay? Write it down and tattoo it on your brain. This is the most dangerous electrolyte on the Nclex. Low potassium low potassium hypokalemia causes muscle weakness and deadly cardiac dysrhythmias. High potassium hyperkalemia causes peak T waves and cardiac arrest. Trick 3.5 to 5. Potassium keeps the heart alive. 3.5 to 5. Shannon, welcome in. Potassium keeps the heart alive. So I'm going to repeat myself because I need you to have it in your brain. Okay? Potassium is one of the, and when I say, it's one of the electrolytes in your body that can cause the most havoc quickly. Okay? Normal potassium, 3.5 to 5. Low potassium, hypokalemia, causes muscle weakness and deadly cardiac arrhythmias. Low potassium, Dia, welcome in. Low potassium is the most dangerous electrolyte in the body. Okay? 3.5 to 5, potassium keeps the heart alive. If it goes outside that range, your patient's heart is in trouble. Is everybody with me? Everybody with me? Look, I got my vape over here and I forgot. 1 in a million, welcome in, and I forgot that I'm recording. All right. I'm getting a whiteboard for you guys too. Okay. Y'all like my drawing? Y'all like my drawing? I know it's orange. K plus 3.5 to 5 keeps the heart alive. Marcia, welcome in. Welcome in. Welcome in. Thank you for your heart, me boo-boo. Come on in and repost and share it out. That's what, girl. Thank you, boo-boo. 3.5 to 5 keeps the heart alive. Potassium. All right, let's go. Glucose, normal fasting is 70 to 100 for your blood sugar. Glucose, 70, 100. Below 70 is hypoglycemia. If somebody is at 73 and they got family catch you. Oh, finally catch you. I know. Thank you, baby girl. Thank you. So, your glucose, if somebody's blood sugar is at 80 and they got long-acting insulin last night before bed and you check it in the morning and it's at 80 or 75, and it's not below 70, do you think you should give them a juice at least, or should you just ignore it and go on because it's above 70? Thank you for reposting, Astrid. Welcome in, Angel. This is important, you guys. Low blood sugar can kill you quickly, too. Anybody in the chat? Come on, y'all. Come on. Come on, y'all. Come on. Should you give somebody juice if their blood sugar is below 80, even though it's not a critical value? Absolutely. And even though 70 is that number, when it goes below, if they got long-acting insulin last night before bed, even if my patient didn't get long-acting insulin, I'm going to give them a juice. Just because that makes me feel warm and fuzzy. Because I don't trust blood sugar. It makes me nervous, okay? It makes your girl nervous. All right, 70 to 100 is the magic number. That's a normal fasting. Below 70 is hypoglycemia. You give glucose first. Critical low is below 50, okay? Nursing emergency. Critical high is above 500. You can think DKA. We will see DKA in simulation, okay? Your BUN and creatinine. These are your kidney function markers. If y'all need me to slow down, tell me. Jessica, welcome in. Thank you for liking the live, Marcia. All right? This light's killing me. BUN and creatinine are your kidney function markers. BUN normal is between 10 and 20. Creatinine normal is 0.6 to 1.2. Okay? Both elevated together. Think acute kidney injury. Lord have mercy. Acute kidney injury, or AKI. BUN elevated alone. Think dehydration. Okay? The kidneys are the body's filter. When they fail, everything backs up. Your body is a kidney's world, and you're just living in it. Do you understand that? Because if you mess your kidneys up, boy, you're going to be up the creek without a paddle. So the reason that how I remember dehydration and with the BUN, your buns is your butt, right? You sit down. If you have diarrhea, and I'm not even being funny, guys. You have to make up goofy stuff you're going to remember. my buns. I said on my buns to go number 2. If I number 2 too much, I'm going to get dehydrated. Right? And if both of them are elevated, that means you got an AKI for an acute kidney injury. The BUN alone is literally dehydration. Okay, you think dehydration. A patient, I got a question. A patient has a BUN of 45 and a creatinine of 3.8. What do you think is happening? What do you guys think is happening if a patient has a BUN? This is by the way, this right here is a question that I pulled from my Nclex prep, just so you know. Like literally out of a Nclex book that I have from forever ago. Okay? Come on, y'all. This is important. Y'all want to pass this test? Let's go. Come on. Let's get it. Let's go. Come on, come on, come on. We got a BUN of 45 and a creatinine of 3.8. What do you all think is happening? Something is failing. What's failing with a BUN and a creatinine at that level? Thank you, Asher. Kidney failure. What electrolyte do you think is causing this problem right now? What are you, not causing the problem, I'm sorry. What electrolyte are you going to be most worried about right now? Because it is excreted through your kidneys. So what electrolyte are we going to be concerned about if somebody's got kidney failure? If it gets too high? We just talked about it. Starts with a P. P. Potassium. Thank you. Thank you, Diana. Thank you, Astrid. That's correct. If somebody is in kidney failure, they're not excreting potassium. So we had a question that we were messing with in class, right? If we get an order to give potassium and somebody, we might need to question that if they're in renal failure, right? Because that's one thing you want to go look at before you go give somebody IV potassium. Oh, let me check their BUN and creatinine. How are their kidney functions? Okay? The Nclex is going to ask you a question like that. So you might want to put an asterisk beside it. It's going to ask you that. It is important information. Okay? I literally highlighted myself in yellow, so I would say it out loud a couple of times. Okay? All right. We're going to go to coagulation and cardiac markers. Okay? I would highly recommend that you write down the therapeutic ranges because a lot of people see these on the Nclex. All right? Do you guys have a pen and paper ready? If you don't, I'll give you a couple of seconds. Everybody, y'all too. I know y'all are watching this and it's not live for you all over there, but I highly recommend that you write these down and you put them on your bathroom window or your mirror or whatever. All right. Here we go. We get into the values that tell you about the clotting and heart damage. These are high-stake Nclex topics. These are high-stake Nclex topics. INR, the normal is 0.8 to 1.1 for a patient on Coumadin. For atrial fibrillation or a mechanical heart valve, the therapeutic range is 2 to 3. I will reread this. INR above 3.5, you hold the Coumadin. I remember like this. INR 3.5, you notify. 3.5, notify. Okay? INR above 3.5, you hold the Coumadin and notify the provider. The antidote for Coumadin is what? I need somebody to tell me what we give somebody if we need to give the antidote for Coumadin. Come on, y'all. I know you know it. 1 is protamine sulfate and 2 is vitamin K. Let's go. What is the antidote for Coumadin? I need to go over here with this. Antidote for Coumadin. Protamine sulfate or vitamin K? Anybody? Anybody? Going once, going twice. Thank you, Astrid. Vitamin K. Yes. So if somebody is taking Coumadin and we're having issues getting their, Diana, honey, you can come up too. Just make sure, if you want to come up, you can. Just make sure you mute your mic. Anybody that wants to come up on the panel, if you're one of my students that are being interactive, you are welcome to come up. So come on up. If a patient is on Coumadin, okay, you want to make sure that you educate them. Oh, it's okay, Diana. I muted you, baby. You're fine. Thank you for being on while you're at work. I appreciate you. Forever Single 365. Welcome in. So I just followed you back, babe. All right. So if somebody's on Coumadin and you keep having to adjust the dose, or the doctor does, because it's not therapeutic, right? You want to make sure you educate them on foods that are high in vitamin K. Because if they're eating a lot of green leafy vegetables and things of that nature, and we keep on having to increase the dose, it's because they're eating all the vitamin K. So even though it's a little bit different mechanism by way that we give it, if they're consuming a lot of vitamin K, it's going to counteract the Coumadin, okay? All right, normal INR is 0.8 to 1.1, 0.8 to 1.1. For a patient on Coumadin, AFib, or mechanical heart valve, therapeutic range is 2 to 3. If it's higher than 3.5, you notify, hold the Coumadin. And the antidote is vitamin K. Trick, INR 2 to 3, Coumadin works. Above 3.5, hold and call. Okay? That breaks that down, what you need to know. All of that. Hamdi, welcome in, love. All of that information is essential for your test. Okay? A PTT measures heparin therapy. Your normal APTT is 25 to 35 seconds. Therapeutic on heparin is 60 to 100 seconds. That is roughly 1.5 to 2.5 times normal. The antidote for heparin is what? What's the antidote for heparin? Because I just told you a while ago when I asked you about the antidote for Coumadin. Coumadin is what? Again, I know y'all think this is redundant, repetitive, but trust me, you'll remember that we talked about it. So our antidote for Coumadin is vitamin K. What's the, thank you, Astrid. What is the antidote for, thank you, C. What is the antidote for heparin? This is going to be on your test. You need to know this. What is the antidote? Thank you for that follow, Casey. The antidote. Come on, guys. Protamine sulfate is the antidote for heparin. If you don't know that, you need to write it down. You need to know. I suggest you guys screen record this too if you're at work, and I appreciate you being here with me, but I don't want you to miss any information. Screen recorder. This is going to be available on my LINK and my bio too, so you guys can go watch it on YT. All right? All right. Remember, H&P, like your history and physical, this is how I remember it. Heparin and protamine. Okay? H&P, heparin and protamine. All right? And K and C, I'm like, okay, they can make some of the same sounds, right? So vitamin K and Coumadin, K and C. That's how I remember it. All right. Troponin. I never say it right. I say troponin. Troponin is the gold standard for a what, guys? What is the troponin a gold standard for? You need to know this too. I highlighted all of the big stuff in my notes. So you guys have a reference, but I got all the big stuff in my notes to make sure that we touch. What? Nikki, baby, welcome in. That's right, Astrid. A heart attack, also known as a MI or myocardial infarction. Sunshine girl, welcome in. She got that Jamaica flag on there. Welcome in, love. Everybody, hold my head. Share us out 5 times. Come on, y'all. We got to push ourselves out because this is a new page. We got to get more people in here. Listen, I tell y'all that I give myself to y'all, but you all got to know. I am giving you my time and my resources because I want to help you out of the kindness of my heart. But what I need you to do for me is please make sure that you tap the screen, you share out my live, you let you let TikTok know that this is a live that's worth promoting so they can send more people to me. Thank you for sharing, Diana. Thank you, Shawnee. Guys, I'm doing this because my health won't allow me to work as much as I used to, and I am trying to build another source of income to take care of my family. So in order for me to do that accurately, I have to have support. So in turn, I just ask that you guys support me by sharing, if nothing else, every day. Get your daily heart me, comment, like, and share, and tap the screen. Okay? Your daily heart me is 1 penny. And if any of you all want to learn how to grow on this app and do what I'm doing one day, I'll teach you that too. Okay? But I got to grow this page because my other page is TikTok Shop. And if any of you all buy stuff off TikTok Shop, go see my page. Please and thank you. And if I don't have what you want, I'll get it. All right. Now, tap screen, share out the live for me. Let's go. All right. Gold standard for MI. The normal troponin is less than 0.04. Okay? Elevated troponin means myocardial or heart muscle damage. It rises within 3 to 6 hours of injury. It peaks at 12 to 24 hours. It stays elevated for 7 to 10 days combined with ST elevation on the ECG. This confirms a STEMI. Okay? There is no other marker more specific to the cardiac muscle than troponin. Okay? One more time. Less than 0.04 is normal. Okay? It rises at 3 to 6 hours. It peaks at 12 to 24. It stays elevated for 7 to 10 days, and you will note a ST segment elevation. Welcome in, Green Eyes, on your ECG. Okay? BNP is in Nancy. We're going to look at this. It's also known as your B-type natriuretic peptide. Okay? We look at this a lot with patients with congestive heart failure. Normal is less than 100. Elevated BNP means heart failure. The higher the BNP, the worse the heart failure. Think of BNP as the heart crying for help. Okay? BNP is the heart crying for help. It can't pump all that fluid. It can't get rid of it. Okay? All right. Now, I'm going to write this down because I want you guys. All right. INR. This is what I want you all to take away from this section. I'm going to get, I told you guys, I'm going to get a whiteboard. However, I can't put all of my personal finances into this, so. Y'all might get tired of my handwriting anyway. My handwriting stinks. All right, less than 0.04. This is what I want you guys to memorize. That's why I'm putting on there. These 3 numbers will appear on your Nclex, okay? They will be on your Nclex. All right? I'm showing the other one. These 3 numbers will be on your Nclex. Take note of them. Put them on a Post-it. Do whatever you will with them, but you better know them when it comes test day. Okay? All right. All right, so we're going to go to the guided simulation. Okay? We got scenarios 1 through 3. All right? So we're going to put all this together now. Y'all ready? I'm going to give you a patient. You're going to read the labs, apply the root stem method, and tell me what the nurse does next. Do not skip to the answers. Read the stem first. Fill in the breakdown box, then look at the options. Okay? Am I able to take away some of the request up boxes? Are they in the way, baby? Bubba Loves, welcome in. I absolutely can, sweetheart. Hang on just a second. I'm sorry. I am so sorry. Let's see. We can do it like... Is that better? Does that work better? I'm about to say you can, if you wanted to come up here. Okay. Shawnee, you can come up too, honey, if you want on the thing. If you guys want to come up and sit on the panel, let me know. All right, baby. I'm sorry. All right. Here we go. Here we go. Y'all ready for the patient? A 68-year-old male with a history of COPD is admitted for increased shortness of breath. His ABG results are, here's the pH, 7.3. His PC, I'm going to write this down and hold it up because I feel like it'll be better if I write it down. So our pH is 7.30. Our PaCO2 is 58. Our HCO3 is 28. Our O2 is 88%. He is using accessory muscles to breathe and is increasingly drowsy. His oxygen is currently at 4 liters per minute via nasal cannula. Okay? pH 7.3. PaCO2 is 58. HCO3 is 28. O2 is 88%. Which actions should the nurse take first? Increase the oxygen to 10 liters via non-rebreather mask. Notify the healthcare provider of the ABG result and the patient's clinical status. Encourage the patient to perform pursed lip breathing or administer a nebulizer treatment as ordered. This is your arterial blood gas, guys. What is the first thing the nurse should do? Are you guys with me? What should we do? Should we increase the oxygen to 10 with a non-rebreather? Should we tell the doctor what the patient's clinical status is and give them the ABG results? Should we encourage the patient to do pursed lip breathing or administer a nebulizer treatment? What do you guys think we should do? Going once? No, but Diana, honey, what do you mean? Oh, 3. Encourage the patient for breathing. Is that what you're saying? I know you said heparin. Okay, so you guys are saying encourage the patient to perform pursed lip breathing, right? Okay, I was trying to understand what you were thinking, Diana. I was like, hang on a minute. Okay, so let me think of how I can explain this. So the answer is to notify the healthcare provider of the ABG and the patient's clinical status. And the reason being, all right, the patient has COPD, right? All right, so he's admitted for shortness of breath. Okay, I'll mute you. I got you, baby. Admitted for shortness of breath. and is using accessory muscles for breathing, and he's getting increasingly drowsy. Okay? So, the patient is having worsening respiratory failure right now. That's what's going on. Okay? So, we need to let the doctor know there's been a change. Right? We could tell him to do the pursed lip breathing. However, something else may need to be done quicker, and that's not going to change what's going on with him because it's getting worse, okay? The ABGs show respiratory acidosis with hypoxemia, okay? Respiratory acidosis with hypoxemia, all right? I want to show you guys this thing that I got. What type of acid-base imbalance is the pH? 7.30. That's low, right? Because 7.35 to 7.45 is normal. Correct? So we're at 7.30. So what is your acid-base balance? I just said it if you guys were listening to me. And trust me, you want to know this, okay? I'm trying to pull my computer up because I want to show you all something. So respiratory acidosis with hypoxemia. I just said it, okay? Thank you, Astrid. I don't know if we got a lag or what, okay? All right. The CO2 is 58, which is high, okay? So they went in opposite directions. That means respiratory, okay? The HCO3 is slightly elevated. So that's like a partial compensation. So it's respiratory acidosis with a partial compensation. Okay? Let's see. I'm going to ABG. Hang on. All right. Hang on just a second. All right, I want to show you all this though. I love this. Let me see. I'm going to pick this up and I'm going to show it to you all. And I'm also going to get a snap. I'm going to put mine online. But if you get something like this, it literally breaks it all the way down to you and it'll help you remember it, okay? Your 7.35 to 7.45. For your pH. And it also kind of tells you, welcome in Amber Jean. It tells you if like which way they go and what that means. So you got your PaCO2 45 to 35, your HCO3 22 to 26. You've got your high alkalotic, your low acidotic. I mean, your high, yeah, I said it right, alkalotic and acidotic. So I'm going to put that up there too. I'll add that so that you guys have that. So that you guys have that as a part of your reference, okay? All right. So it's respiratory acidosis with partial compensation. So the root asks for the first action. So I'm going to break this down to you all, okay? The framework ABCs. Breathing is compromised. The nurse must notify the provider. The patient may need a BiPAP or intubation, okay? It happens all the time in the ICU. We have to put people on a BiPAP and intubate them very quickly, okay? This stuff happens very quick. You can eliminate, and I'm breaking this down to you how you can eliminate the other answers. You can eliminate A, okay? Why is a dangerous COPD patient rely on hypoxic drive? High flow O2 suppresses the drive to breathe and causes CO2 retention. This is lethal. This is a lethal error on the Nclex. You never want to turn a patient that has COPD in an exacerbation up to 10 liters. Okay? You don't. The doctors have to make that decision. As a nurse, you can't make that call. Okay? Welcome in, AB baby. Baby, did I say it right? We can also eliminate C and D. Pursed lip breathing is a comfort measure, not a priority. Okay? A nebulizer may be ordered but does not address the critical ABG and the need for the provider notification. Step 6, we can confirm B. Notify the provider first, then the provider orders the next intervention. The nurse does not escalate independently without notification. Does this make sense? Why we selected notify the provider? Okay? And I'm going to read you the rationale, and this is straight from my Nclex question book that I use. It says the ABG shows worsening respiratory acidosis with hypoxemia. The nurse must notify the provider immediately. COPD patients on high flow O2 can lose their hypoxic drive. This is the most tested Nclex pharmacology respiratory error. Say, when in doubt, notify. When critical, notify immediately. Okay? Now, we have a confused post-op patient for our next patient. All right? Which lab value requires the nurse's priority intervention? We have a hemoglobin of 9.2, a potassium of 3.8, sodium of 122, and a glucose of 98. Welcome in, Brianna. Which one of these require immediate nurse intervention? We've got a new onset of confusion, and we have a what? A sodium level that's out of whack, right? Is everybody following us with this? These are the levels. Everybody is understanding. That's right, Brianna. Everybody's understanding where we are. Welcome in, Yoli. With these levels, everything else is within normal range anyway. But the increased confusion, it could have been, if somebody has, thank you, Diana, hypoglycemia, they could have, so your hemoglobin and potassium, it would have been easy maybe to exclude those. Let me give you the rationale. The most alarming thing in this scenario is the confusion, the new onset of confusion. It's a post-op patient, and that's always a red flag. Always a red flag when it says post-op, okay? So, the critical value check. Which lab is outside of normal range? And we've decided that it's sodium, which is correct. It's critically low, okay? Welcome in, Merlande, that came in through Diana's invite. All right, your normal sodium is 135 to 145, okay? Your hemoglobin is 9.2. That's normal, but it's low, but not critical. I said it's normal. It's low. It's not critical. Your potassium is 3.8. That's normal. Your glucose is 98, and that is normal. Okay? Connect the dots. How does the sodium of 122 explain the confusion? Hyponatremia below 125 causes cerebral edema. You need to know that. Hyponatremia below 125 equals cerebral edema. The brain swells. This directly causes confusion, restlessness, and can progress to seizures. Okay? Does everybody got that? Sodium less than 125 can cause cerebral edema. The brain swells. Confusion and restlessness, and can progress to seizures. Okay? So, moving on from there, we can eliminate B and D, the answers B and D, because 3.8 potassium and glucose of 98 are both normal. No interventions needed. Cross them off immediately, which leaves us with 2. Okay? Hemoglobin of 9.2 is low. It explains fatigue, but does not explain confusion. It's not the priority. It's 9.2. It's no big deal. All right? So, that leaves us to confirm the answer of sodium. Diana, yes, that's correct. Of 122. We have a sodium of less than 125. Cerebral edema, confusion, and restlessness with the potential for seizures. Okay? The Nclex always gives you a clue. The confusion is the clue here. I'm going to say it again. The Nclex always gives you a clue. And the clue is confusion. Okay? Welcome in, Nclex PN. Welcome in. So, whatever you need to do to remember that, by all means do so. Okay? We got a cardiac patient on Coumadin. I'm going to read it. A 58-year-old male with AFib is admitted for a routine follow-up. He takes Coumadin 5 milligrams daily. His current labs are as follows. We have an INR of 4.2. We have a PT of 38 seconds. We have a potassium of 4.1 and a hemoglobin of 13.5. He has no active bleeding but reports mild bruising on his arms. These are your lab values for this patient. INR 4.5, PT at 38, potassium 4.1, hemoglobin of 13.5. I'm doing the recording too, guys. All right, here's our answers. Do we administer the Coumadin dose as ordered? That's A. B, hold the Coumadin and notify the healthcare provider. C, apply pressure to the dressing to the bruised areas. D, draw a repeat INR in 4 hours. Welcome in, Marilyn. I appreciate you. C said, I'm saying C on here, answered. We got B. Brianna says B. Anybody else? Cheyenne, welcome in, love. You guys are absolutely correct. The answer is B. Now, I'm going to break. The reason that I'm reading through the breakdown is because I want you guys to understand what we initially started with day 1, the root stem analysis. Okay? I want you to begin, even though I'm going through lecture, and I know this is boring. I know it's boring, and I'm sorry. But I'm telling you, this stuff is going to be on the test. If you are able to use my strategy, using root stem, you can answer your questions easier. Okay? So that's why even though we know what the answer is right now, I want you to understand the breakdown. Okay? So the clinical concern here, the INR is 4.2 on a patient taking Coumadin. The therapeutic range for AFib is 2 to 3. This is supra-therapeutic. Okay? The INR interpretation. What does an INR of 4.2 mean? The blood is too what? Is it too thick or too thin? I want y'all to know I used to struggle with this. Oh, I struggled with this so hard. It used to drive me insane. And I know you think it's a dumb question for me to ask, but it's really not because it gets confusing. Welcome in, Nancy. Is a INR of 4.2, does that mean the blood is too thick or too thin? Come on, somebody. Give me the answer. Give me the answer. A 1 for thick and a 2 for too thin. 4.2, it's high. What does that mean? That means their Coumadin levels are elevated. And Coumadin does what to the blood? Thank you. So that means the blood's too thin. The patient is at high risk for serious bleeding, even without visible bleeding right now. Okay? Even if that patient does not have visible bleeding, they can still be bleeding. Okay? Somewhere you don't know. Maybe in their GI tract. They could have a brain bleed. You never know. Okay? So here's a safety rule for the Nclex. I highlighted this. Never give a drug when a lab value, and I know this is a no-brainer, when a lab value indicates toxicity. INR above 3.5. Okay? Hold Coumadin and notify. 3.5, notify. Can y'all put that in the chat for me? 3.5, notify. You'll remember it later. I promise. 3.5, notify. Here's the other breakdown. Administering Coumadin when an INR is already 4.2 would be a med error. Thank you, Rose. I appreciate you, love. It would be a med error. Okay? The drug is already at a toxic level. This is the most dangerous wrong answer. Administering the drug is the most dangerous wrong answer. Okay? An accurate order should tell you not to give it if it's above 3.5. The doctor has parameters. Whatever those parameters are, because some patients are different. But above 3.5 is notify. At 4.2, that's a toxic level. Folks from the FYP, come on in. My name is Coach Shay, and I am your Nclex coach. If you want to learn test-taking strategies, welcome on into the live stream. I can see TikTok showing me when people are outside looking in. They're on our porch looking at us. Y'all come on into the live stream. All right. Now, so we eliminate C and D because applying pressure to bruises is a comfort measure. Okay? It's not the priority. Repeating the INR in 4 hours delays a critical intervention, guys. The right answer will never be delay care. You will never delay care. It's always going to be a wrong answer if you select the answer that delays care. Okay? The current value is already critical. We know that, and we need to do something about it right now. Okay? So the answer, holding the warfarin or Coumadin, that is the answer. Notify the provider, document, anticipate a vitamin K order if the INR continues to rise or bleeding develops. Because vitamin K is what? The antidote for Coumadin. And protamine sulfate is the antidote for heparin. Okay? All right. Now, you learn how to read the body, CBC, electrolytes, coagulation, cardiac markers. Okay? These are the numbers that tell you whether your patient is stable or in crisis. Okay? These are some of the most asked questions on the Nclex. Any of you all that have already taken the Nclex, are these ringing a bell? I mean, there is a big test bank for the Nclex. It's been years since I've taken my Nclex. However, I know that back in my time, your questions would go anywhere from 85 to 246, if I'm not mistaken. And a lot of people that I've spoken with recently see these labs. Does any of this ring a bell? Did you guys see these on your test? Anybody? So this is what I want you guys to do for me, okay? Because you all have got, you went and you got all of the information that I provided for you. You got your lab reference, you got your simulation, and you got your handout. You have scenarios 4 through 7 in your simulation package. Don't look at the answer key yet. Please don't do that. I want you to fill in the guided breakdown, the box for each one, okay? And I want you to have it tomorrow. Your study reference card for tonight is know the critical values, okay? Know the antidotes. That is your foundation for what to do next. All the things we talked about today, you need to know the critical values and what to do about it, okay? I want you all to be successful, and I cannot stress enough how important it is to know these values and the intervention. This is a part of critical thinking. Remember, your question is your patient, and there's always going to be noise. Okay? Nazari, welcome in. In order for you to easily break this down, I gotta forget to look at the other camera. You have to break your question down and use the root stem method. Okay? The root stem method will work if you apply it. I don't know you guys individually and personally, but what I can say is this. I told you guys I have ADHD and I'm dyslexic. I had to teach myself a different way, different from everybody else. And the reason I had to do that is because I don't comprehend like everybody else does. Okay? If you all apply this method, it will work. That means if you look at the answer key while you're trying to do the scenarios of 4 through 7, if you look at the answer key first, you're doing yourself an injustice. Okay? So look at it last. All right? You really learning to break these questions down, doing root stem and being able to identify the root and stem, the meat and potatoes of the question. That is what I'm teaching. That's all about the strategy. This entire thing is about root stem analysis. It sounds redundant and repetitive, and I know labs, Ari, welcome in. I know this is boring. I wish there was a way I could make it so that it's not boring, but it is so critical that you guys know these values and know what to do, because this could, if you're setting, just think, I work in the ICU. Our little nursing pods are right outside the door of the patients, and like I'm sitting at a desk. There's a monitor here and a monitor here, and I just noticed that I'm looking over and I see, I'm like, oh yeah, a little ST elevation and whatever, and I'm looking and looking and looking. But I don't know those lab values. Now, to be honest with you, once you get through your test, your normals will be right there for you. But you need to know that for your patient. When you're taking report, those are things you need to write down. Okay? Hemoglobin, white blood count, BUN, creat, potassium. I write down my magnesium. Yeah, if they're on heparin, if they're on Coumadin, depending upon what's going on with the patient is important. So I'm not saying you won't have a reference in the real world, because you will, but there may not be time for you to go look through and try to figure something out. You have to know this stuff. Welcome in, Devin. You have to know this stuff sometimes off the fly of a whistle. Okay? And yes, I'm country. I say weird things. All right? So I want you guys to do 4 through 7. I know everybody has to work, and I know everybody's already busy, and I get it. That's why I try to condense it as much as I can. But practice for root stem analysis is what is going to stick in your head and help you the most. And I know by me reading it to you, it's not as good as you doing it yourself. Because we're going to go over it, and the rationales, okay? All right? Does anybody have any questions? Welcome in, Keisha. For everybody that just came in, guys, if you weren't in here in the beginning when I said I'm going to put a price on my material for class. I'm putting a price on it, but you guys will have a code, or I got to go in and see what I need to do, a discounted thing for it so that you get it for free. Other people are using my material that aren't a part of our class. So if you don't come in and check in class, then guess what? You're not getting my material for free. It was actually a couple organizations, because every time somebody goes and gets something from my store, it sends me an email. And I just so happened got to looking through there, and I'm like, what is going on? So I got really busy last night because I had a flub. My computer has something going on it, so I had to do everything on a tablet. It was crazy. Okay? So I'm going to show you guys. We had somebody, I want to read you